11. Which patient best fits the diagnostic criteria for hypertensive emergency? An 18-year-old male with severe traumatic closed head injury who is unresponsive with a blood pressure of 190 over 110. A 65-year-old female with headache, confusion, papilledema with a blood pressure of 190 over 105. An 83-year-old male with mild chronic dementia and a blood pressure of 210 over 105. A 45-year-old male with 2 plus proteinuria and normal urea and creatinine with a blood pressure of 200 over 105. Now we are saying an hypertensive emergency is a life-threatening condition where there's going to be severe elevation of BP greater than 180 systolic or greater than or equal to 120 diastolic. But there should be an acute or new or worsening damage to end organs. So that part is very important. Okay. Besides the elevated BP, there should be either acute or new or worsening damage to the end organ. So the features would depend on which organ has been involved. For example, if the neurological system is involved, someone is going to be in what we call hypertensive encephalopathy, where they are going to have headache, confusion, seizures, altered mental status, visual disturbances, or they can have ischemic stroke, or they can have intracranial hemorrhage or subarachnoid hemorrhage. And if it is the cardiovascular system involved, the symptoms, the target organ system or the target organ symptoms we are going to have will include acute myocardial infarction, like the heart attack, can be unstable angina, left ventricular failure with pulmonary edema that can present a shortness of breath, cough, crackles in the lungs, or there can be aortic dissection that will present a sudden severe back or chest pain, uh, which is different in the blood pressure, different, or there also be a difference in blood pressure between the arms. And then for the renal, the patient will present with AKI. And if someone has got AKI, you see oliguria, uremia, and elevated creatinine. Please take note of those three: oliguria, uremia. So if there's no uremia, uh, there's no this triad. So oliguria, uremia, elevated creatinine, sometimes there can also be protein in urine and hematuria. If it is the ocular that is involved, the eyes, there will be hypertensive retinopathy, and then there can be cotton wool spot, there can be papilledema. If it is in pregnancy, there will be severe preeclampsia or even eclampsia. So here, if you look at option A, an 18-year-old with a BP, I mean with severe traumatic closed head injury who is unresponsive with this BP. Of course, the BP is high, but then what is the associated target organ injury? So is it that the BP is the one that caused this unresponsiveness? No, not likely. This unresponsiveness is likely just because of the trauma. So this is unlikely because the BP, if we are supposed to say hypertensive emergency, it's the BP that should cause that end result, or that damage to the organ. When you look at B, a female with headache, confusion, and papilledema with a BP that is high, likely this is going to be true. The BP is high, and then they can have headache, confusion, papilledema. These are CNS symptoms, isn't it? For C, a 3-year-old with chronic dementia. Now, with a BP, of course, the BP is elevated, but chronic dementia, this dementia is likely not caused by the BP because it's chronic, it's been there. And then for D, a 45-year-old male with 2 plus proteinuria and normal urea and creatinine, and then the BP is elevated. The BP is elevated, of course. If the BP is elevated, I'm expected that there is AKI. Besides the proteinuria, the urea shouldn't be normal. The creatinine should be normal because in AKI these guys are also elevated. So this 2 plus proteinuria might not be related really to the BP. It might be just maybe it's just a nephrotic syndrome. Okay, and then you end up also having the high BP or just any other condition. So unrelated. So the best option here would be B. Number 12 is saying a 65-year-old man presents with progressive shortness of breath. Other than a history of heavy tobacco use, the patient has benign past medical history. Breath sounds are absent 2/3 of the way up to the left side of the chest. Percussion on the left chest reveals less resonance than normal. While you place your hand on the left side of the chest and have the patient say 99, no tingling is appreciated in the hand. The trachea appears to be deviated towards the left. Which of the following diagnosis is most likely? Bacterial pneumonia, bronchial obstruction, pleural effusion, pneumothorax. Any thought on this one? So remember here the problem is actually the description is on the left side. And what you've been told is that they have got breath sounds absent. So no breath sounds on the left up to two-thirds the way. Okay, up to maybe somewhere there are no breath sounds. And then percussion note again is less resonant. So percussion less or reduced resonance. Another thing is when they say 99, that is tactile fremitus, isn't it? So tactile fremitus, they are saying is no tingling is appreciated. So no vocal fremitus. The trachea appears to be deviated towards the lesion. So the trachea is going like that. So what is the most likely diagnosis amongst these? Any thought?
I think bronchial obstruction.
Okay, why do you go for this one?
Okay, so for a pleural effusion and the tension in the thorax specifically, if there's a pleural effusion, inside is a pleural effusion, meaning fluid is accumulating in the pleural space. So it's a compress on the lung, and the lung is compressed on the trachea. So the tracheal deviation is the opposite side of the lesion. That is also the same in pneumothorax because of the air accumulating. You've got compression of the lung, and that lung is compressing the trachea, so the trachea will deviate to the other side, which is not the case in this question. Because in this question, it looks like the side of the lesion is where the trachea is deviating
Okay.
while remaining with B and A. And for a bacterial pneumonia, specifically pneumonia, I expect that from the percussion, I should be able to hear the dull percussion note. And for the tingling sensation when the patient is asked to say 99, the tingling sensation, it is not an obstruction, then it should be heard. So I remain with
Okay. Thank you so much. So for pneumonia, tension pneumothorax, deviation of the trachea is to the opposite side. When you, sorry, pleural effusion and tension pneumo, deviation of the trachea is to the opposite side from the lesion. For pneumonia, because you have got a consolidation, you expect that when you are percussing, there should be okay. We expect that when you are percussing, there should be a DAO percussion note. And then again, when it comes to vocal resonance in a pneumonia, it actually should be increased because you remember I've got consolidation, you have got a solid, and sound travels faster in solids than in liquids, and the sound travels faster in liquids than in air. Okay, so that's why the best option will be bronchial obstruction. Number 13 is saying a 32-year-old man presents to the emergency department with a 5-day history of fever, chills, and malaise. He recently returned from a trip to Mansa. On examination, he is febrile and thrombocytopenia. Okay, on examination is febrile and has mild hepatosplenomegaly. Laboratory findings reveal monocytic anemia and thrombocytopenia. Which of the following clinical features most strongly suggest malaria in this patient? Jaundice, hepatosplenomegaly, periodic fever pattern, generalized lymphadenopathy. Any thought on this one? Okay, Thank you so much. Yeah, likely if it's malaria, the fever in malaria happens after a certain period. For example, it will be happening after 48 hours or after 72 hours. Jaundice can be a feature of many things, hepatomegaly, hepatosplenomegaly, many things, lymphadenopathy, many, but for the periodic fever, that can help us in pointing to malaria. 14 is saying a 25-year-old woman is admitted for management of severe malaria. She is comatose, febrile, has uremic frost and bilateral fine basal crackles on lung auscultation. Her urine is a dark brown color. A blood test reveal a white cell count 14,000, HB9, urea 25 which is high, creatinine 800 which is high, potassium 5.6 which is high, sodium 138 within the normal range, pH 7 which is acidic, right? That's meaning acidosis. And then which of the following abnormalities do not meet the criteria for hemodialysis in this patient? Uremic encephalopathy, pulmonary edema, resistant to treatment, metabolic acidosis, where the pH is 7.1. Okay. And then hyperkalemia, where potassium is greater than 5.5. Any thought? So here the answer is B. So when you want to do this dialysis of blood, hemodialysis, the indications we can use the R, A, E, or U. So the R is acidosis. Okay, so there should be severe acidosis, and that is defined as a pH which is less than 7.1. Okay, and for this question, the pH is actually 7, so that meets the criteria. Or if we are not looking at pH for the acidosis, we can look at uh, actually that's a big feature we look at. I was thinking of another parameter. And then for A is the electrolyte abnormalities, and specifically you look at potassium here. If the potassium is greater than, remember the normal potassium is about 3.5 up to 5, isn't it? But if the potassium is greater than 6.5, then that is going to be abnormal. Hyperkalemia specifically is what we are interested in, should be greater than 6.5, but this is 5.6, so that is not greater than, so that's an exception. Okay, again for the electrolytes, except just looking at the potassium, we can also look at ECG changes like a peaked T wave, loss of the P waves, or maybe a sine wave, like the wave becomes like this. This is not how a ECG should be. It should be like that, and then it is continuing. But if it forms a sine wave, that also would mean electrolyte imbalance. And then the I is ingestion or intoxication. So this is basically overdose of dialyzable toxins. And for those toxins, we use slime to remember them. You have got silates, an example being aspirin. And then L is the lithium. I is isopropanol, the M is methanol, and then E is ethylene glycol. And then O is overload, meaning that there's volume overload. You have got a lot of fluid. For example, pulmonary edema. Okay. And then the U is uremia, where you have got uremic symptoms. What happens that, what are the symptoms of uremia? This includes uremic pericarditis, where there's going to be inflammation of the sac of the pericardium, and then uremic encephalopathy, which presents as mental status altered, seizures, coma, or they can even be uremic bleeding because this abnormal uremia can cause dysfunction of the platelets. Okay, or even the urea can actually, because urea can also go and stimulate the chemoreceptor trigger zone, and that causes the nausea and vomiting. Okay, so the exception here is D. Number 15 is saying a 74-year-old woman has pain in her left hand and right knee. When which started months ago and is now interfering with her activities. The pain gets worse as the day progresses. There is no history of any trauma and she is otherwise well. Taking over the counter paracetamol usually relieves the pain. On examination, there is bone tissue swelling of her second and third DIP, distal interphalangeal joints, and in the left hand and cryptus over the right knee with flexion. There is no erythema or joint effusion. Which of the following is correct regarding osteoarthritis? Osteoporosis is associated with reduced risk of developing osteoarthritis. Professional athletes have a low risk of developing osteoarthritis. Family history of osteoarthritis is not associated with development of osteoarthritis. Increased range of joint motion is associated with reduced risk of developing osteoarthritis. So, of all these, which one is correct about osteoarthritis? Okay. Why do we go for A? Why does osteoporosis reduce the incidence of osteoarthritis? Okay.
I'm not sure about the specific one, but I just use elimination by weighing out the amount.
Okay.
But a similar statement before is also there in human blood.
Okay. So when you look at the risk factors, thank you so much, Doc. When you look at the risk factors for osteoarthritis, you have got trauma, joint shape, alignment, usage. If you use the joint more, you are likely going to develop osteoarthritis. That's why medical people, you're always walking, you're always up and down, you are likely going to develop this thing. And then you also have hereditary, so family history, hormonal changes, also obesity, even high bone mineral density. So, for example, in osteopetrosis, so if you have got high bone mineral density, you are going to develop osteoarthritis. But osteoporosis is a condition where there is breakdown of bone. So there is a decreased bone mineral density. So that is actually going to be reducing the risk of osteoarthritis. So the answer is A. Number 16 is saying a 45-year-old woman reports to her doctor for an annual health visit. She's worried about diabetes because her mother is diabetic and has developed complications. On exam, her vital signs are normal and her BMI is 33. A blood draw in the office is 12.2. And that's elevated, isn't it? Since they're normal support, anything greater than 11.1. So, what is the most correct next step? Prescribe diet and exercise therapy and re-evaluate blood glucose in 3 months. Repeat fasting glucose measurement on a subsequent day. Start metformin and lifestyle modification. Prescribe a glucometer and instruct the patient to keep a log of plasma glucose levels to review with her at a return visit in 2 weeks. What do we think on this one? Remember in the diagnosis of DM, right? You are for the oral glucose tolerance test, it should be greater than or equal to 11.1. Same way with the random blood sugar. But if it's greater than 1, it should be followed with the signs and symptoms of diabetes. If you find that that's true, to confirm that there is indeed diabetes, you need to do the fasting guy and it should be greater than 7. So fasting is what you use. If fasting glucose is not there, then you not conclude. Of course, you can also use the glycated hemoglobin, which could be greater than or equal to, that's 6.7. Okay, so here you're supposed to, if you find that the random is elevated, also do repeat a fasting glucose. So the best option here is B. You repeat the glucose. You don't just there and then start metformin, because maybe this patient was just eating. It is postprandial. You don't know, right? So that's why for diagnosis, we always want to use the fasting. 17 is saying a 62-year-old man reports early satiety. Yes, doc.
How have you excluded the answer, which is option A?
Option A is saying prescribe diet and exercise therapy and reevaluate. Now, this patient has come to the hospital, right? Look, she's 45 years. So if it was to develop, if our fear is that her mother was diabetic, but she's 45. By this time, a diagnosis of DM would have already been made if it is diabetes type 1, right? Our only fear is that her mother had diabetes. Maybe she's thinking maybe I can also have it, but she doesn't have any symptoms at all. And just a random blood sugar is the one that is elevated. So just because of a random blood sugar, we can't tell the patient to start exercising, doing therapy evaluation after 3 months, because it might be just maybe the patient just ate before they came to the hospital, right? Yeah. It might just be that the patient just ate and then they came to the hospital. That's why this one is elevated. So if we want to confirm that the patient is actually having diabetes, we should do a random blood sugar. Now, a family history predisposes someone to having diabetes. But by the age of 45, if someone who is 45 develop, because they have lived all this while, if they develop at 45 years diabetes, less likely is going to be type 1, because this age is way, way high. It's likely type 2. Because if it is type 1, they would have developed it some time back with this age. Yeah. Okay. Number 17. Yes, doc. Yeah, again, the BMI is high. If we look at type 1 and type 2, in type 1 diabetes, is the patient likely going to be fat or slim in type 1? So type 1, they are likely going to be slim. In type 2, that's why they're expected to be fat, isn't it? Type 2. But then this one, her fear is her mother. So when you are looking at the mother's aspect, she's like, the fear is that she might have developed type 1, and which is less likely that she's going to be fat, because this woman is fat. If she has diabetes, then likely it is type 2. And for you to diagnose it, you are going to be looking at uh, you're going to be looking at what? The random blood sugar, right? A 62-year-old man reports early satiety, fatigue, and generally feeling unwell. On examination, he has a large spleen, appears pale, and the rest of the examination is normal. His blood count is abnormal. The white cell is 50,000, increased the mature granulocytes. Hemoglobin is at 9, platelets is 450. With the following cytogenetic changes, he is more characteristic of his condition. So look at this. We've been told that this bro actually has got generalized, they are feeling general unwell, fatigue. These are symptoms of anemia. Actually, what happens is that in leukemia, there can be anemia, a reduction in the white cells. There can also be thrombocytopenia, or it can even be thrombocyte. What's that? Thrombocytosis. Okay. Actually, the anemia is going to be there. the white count. But then what we've been told is that when they did the blood cells, they are mature granulocytes. Okay, which of the following cytogenetic changes is likely? So if you are suspecting a leukemia and you have got mature cells, it can't be acute. So since it can't be acute, what you are going to be thinking about is chronic. So it can either be chronic myeloid or chronic lymphocytic. And from what we've been given here, deletion of chromosome 14, reciprocal translocation of 9 and 22, which is Philadelphia chromosome, translocation of the renal artery stenosis, oncogene, translocation of 814. So likely the finding will be reciprocal translocation of 9 and 22, right? Because we'll more likely will be suspecting chronic myeloid leukemia. 18. A 43-year-old woman with a 2-month history of epigastric pain, occasional nausea and vomiting, and melena is seen for upper gastrointestinal endoscopy. On endoscopy, a duodenal ulcer was noted, and urine testing was positive for H. pylori. Which of the following factors is not correct in describing the pathophysiology of this illness? In, increased acid secretion, gastric metaplasia, stimulation of immune response, bacterial invasion of the mucosal epithelium. What do we think of this question? Okay, remember this guy has got epigastric pain, occasional nausea, vomiting, melena, endoscopy shows a duodenal ulcer, and then H. pylori is positive. Now, H. pylori, because this is an ulcer, there's going to be increase in production of acid. And this acid, when it is going to the epithelium of the duodenum, every time acid is going in an area, what it does is that it starts to change the epithelium of that area to be like the epithelium of the stomach because that's the one that is resistant to the acid. Okay, so this intestinal epithelium will start undergoing metaplasia to that of the stomach. So B is also true. C is saying stimulation of an immune response. That is also true. There will be an immune response because of course, you have got these cells and also the injury that is happening to the mucosa. But now, H. pylori itself, it doesn't invade the epithelium. What causes really the damage is the products from the H. pylori. For example, the urease, there's also the VAX-A. So it's the products. H. pylori itself is not invasive. It doesn't chew through or pass through the epithelium to cause injury itself. So D is the option. 19 is saying you are called to review an 84-year-old man who has a persistent confusion 2 days after cholecystectomy. He has a background history of diabetes, but the surgical team reports no complication. 2 days after surgery, the nurses note that he began s- to speak nonsensically, see family members, and intermittently become agitated, try to get out of bed. Apart from altered mental status, his physical examination is normal. What is the most likely diagnosis? Acute onset Alzheimer's dementia, vitamin B12 deficiency post-surgery, post-surgical delirium, by, by hemispheric stroke causing encephalopathy. Any thought on this one? Okay, so this one we've been told that this patient is presented with confusion 2 days after cholecystectomy. So there's after surgery, someone can develop confusion. We call it post-surgical delirium. For these other conditions like acute onset Alzheimer's disease, it will not come 2 days after. It develops over a time, right? So the best option is after surgery delirium. Number 20 is saying a 80-year-old male patient is admitted with a femur fracture. Although his vitals are stable, he reports symptoms of heart failure. You hear a heart systolic murmur at the base of the heart that radiates to the carotids, and the crackles at both the lung bases. His his orthopedist wants to nail his femur fracture as soon as possible, which essential tests must be performed and interpreted before allowing this patient to go for surgery. Remember, this patient has got is really the vitals are stable, but he has got symptoms of heart failure, and then he has got a has historic mama that migrates or radiates to the carotids, and then basal crackles bilaterally. So before it can undergo this, maybe it's an open reduction, nailing or such for the femur. What should be done? Echocardiogram, CT scan of the chest, electrocardiogram, cardiac catheterization. Any thought on this one? Okay. Any explanation? Now, when you look at the presentation, when you have got a mama, a systolic mama that goes to the carotid, that is specific for aortic stenosis. That feature is classic for aortic stenosis. And because the stenosis, it means that blood will be failing actually to really go upwards, isn't it? Because the aortic valve is actually stenosed, blood will be failing to go to the rest of the body. So what happens in this case, and then they have got symptoms of heart failure, even basal crackles and such. So what you want to do is you want to assess the function and the pathology of the valve. If you find out that actually the aortic valve, because you're suspecting aortic stenosis, it will actually help in determining the treatment perioperatively. Like for example, how the anesthesia team is going to do their work. Okay, so it is very important to know the function of the valve, and if you want to see the pathology of the valve, you use echo. So the best option there is A. 21 is saying you are asked to give a class presentation on risk factors and association of asthma. Which of the following will you say is always true of individual with asthma? Have a person or family history of allergic disease, display a skin test reaction to extracts of airborne allergens, demonstrate non-specific airborne hyperirritability, have a supranormal serum immunoglobulin A. For the previous question, the answer is A, echo. Any thought on this one? Which feature is always associated with asthma? Any thought? Okay, so when you look at the options, A is saying have a person or family history. We all can't see. Are there people that can see my screen? Okay, thank you so much. So when you look at asthma, asthma can be divided into the intrinsic asthma and the extrinsic asthma, right? And then you are going to have also, for this intrinsic and extrinsic, different causes. For example, the intrinsic, you are really having this. That's the one where there is atopy, isn't it? Where the body is going to be producing. You have got the IgE coming in. It's basically the type 1 hypersensitivity. Where if the first time you're exposed to an allergen, what is going to happen is that when you're exposed to an allergen, that allergen is going to go and bind to the mast cells. Okay, it will actually go. Yeah, it is going to go. It doesn't go and directly bind to the mast cells, but what is going to happen is that an allergen is going to lead to the stimulation of the production of of IgE. IgE binds on the mast cells and the basophils. The second entry of the organism, what happens in that case is that it will cause the granulation of the mast cells and the basophils. Now, for the other types of asthma, which are non-atopic, for example, you have got exercise-induced asthma, cold-induced, okay, or weather-induced. So those ones, there might not be any family history. So have a personal or family history. This is not always true. For example, exercise induced, there might not be history. Display skin test, again, for the exercise induced, might not, there might not be skin test, because this one for the skin test is specifically for allergic, for the one where you are responsive to the allergens. And then she's saying demonstrate non-specific airway hyperactivity. This is actually true. Okay, in every type of asthma, the airways are hyperresponsive. Actually, the characteristic features is that there is obstruction of the airways, there is hyperresponsiveness of the airways, and then there's airway inflammation. And then this saying of supranormal serum Ig. This Ig is again specifically for the one that is mediated by the immune system, and it's not all types of asthma that is like that. Number 22 is saying a 40-year-old woman is referred from a peripheral hospital for management of complicated malaria. She presents with fever, altered mental status, severe and seizures. Ring forms are noted on a blood smear, and the diagnosis of cerebral malaria is made. Which of the following is associated with increased mortality in malaria? Hyperkalemia, hypoglycemia, raised creatinine, hypocalcemia. Any thought on this one? Okay, thank you so much. So specifically, please let's get to review again the 10 features of severe anemia. I mean severe malaria. Specifically for someone that has got complicated or severe malaria. Hypoglycemia is going to cause these seizures, and that is the one that results in increased mortality. Number 23 is saying a 19-year-old man presents with malaise, nausea, and decreased urine output. He was previously well and his physical exam is normal, except for an elevated jugular venous pressure and the pericardial rub. His electrolyte reveals acute kidney injury. Which of the following findings on the urinalysis is most likely in keeping with acute glomerulonephritis? White blood cell cast, granular cast, erythrocyte cast, hyaline cast. Any thought diagnosis of glomerulonephritis? Which one? Okay, thank you so much. So for someone that presents with hematuria, now we know that if someone has got hematuria, you can deduce. Okay, here is the kidney, then you are having the bladder there, and then the urethra. If there is an injury to the urethra or even the base of the bladder, that is likely to present with a terminal, actually not terminal, but that's early, isn't it? Okay, early hematuria. If there is injury to the bladder upwards there, that is likely going to be terminal, right? Terminal hematuria. If there is injury to the kidney, that is going to be hematuria that is throughout. But specifically, if someone has got hematuria and you want to tell if this hematuria is because of kidney injury or because of glomerulonephritis, you are going to look at the red cell cast or the erythrocyte cast. If you see them, it means that that injury is actually coming up. The hematuria is coming from up. Okay, so the answer is C. 24 is saying a 34-year-old woman develops a red rash over her cheeks, frequent oral ulcers, and pain and swelling in both wrists as well as in several small joints and in her hands. Medical evaluation reveals positive ANA and nuclear antibodies and 3 plus proteinuria. Which of the following organ involvement will cause the most symptoms during the course of this disease? Renal pathology, musculoskeletal pathology, thrombotic events, and skin changes. Any thought on this one? Okay, so if someone has got positive these lupus and then there's proteinuria, there are oral ulcers, there is pain, swelling, there is also a rash on the cheek. This is likely systemic lupus. And 90% of the symptoms that the patient presents with are musculoskeletal symptoms. Okay, so it's B. Specifically, there's actually going to be these joint problems, which are described as non-corrosive. 25 is saying an 18-year-old male presents with vomiting and abdominal pain. In the last 2 weeks, he noticed progressive polyuria, polydipsia, dizziness, and fatigue. He did not notice any other prodrome symptoms and denies any drug use or alcohol abuse. On exam, he is ill looking and thin with dry mucous membranes. His vital signs are temperature 36, heart rate 125, BP 90 over 60, and respiratory rate of 30. The remainder of his exam is normal. His random blood sugar is 22 millimoles per liter, and he has ketonuria. What is the most likely underlying pathophysiology causing his illness? Autoimmune destruction of pancreatic beta cells, peripheral tissue insulin resistance and the inclusive hepatic glucose production, subacute pancreatitis, genetic defect in the skeletal muscle, insulin receptor. What do you think of this one? Okay, so this patient has presented with polyuria, polydipsia, dizziness, fatigue, and then there is also elevated the random blood sugar. This is meaning that this patient has got DM. But then besides that, he is ill looking, the vital temperature is 36 elevated. Okay, really not that elevated, but the heart rate is high, the BP is low, and then what else? Okay, okay, just from that, there's also vomiting and abdominal pain. Vomiting, abdominal pain, the elevated heart rate, low BP, this might be pointing us to diabetic ketoacidosis. So, DK is a complication of diabetes type 1. And in type 1, the problem is that there is autoimmune destruction of the pancreatic beta cells. Okay. If it was type 2, would have picked B, which is peripheral tissue, insulin resistance. And there the complication is non-ketotic hyposmolar coma, honk. 26 is saying a 25-year-old woman is diagnosed with aplastic anemia. Which of the following statements regarding aplastic anemia is correct? There is no association between aplastic anemia and leukemia. It is characterized by pancytopenia and increased reticulocyte count. Most cases are acquired and caused by autoimmune pathology. It often it is often associated with lymphadenopathy and hepatomegaly. Any thought on this one? So we want what is correct about aplastic anemia. When you look at A, it's saying there is no association between aplastic anemia and leukemia. Aplastic anemia, there is a reduction in all the cell lines, the platelets, the white cells, and the red cells. Leukemias, that can also happen, but then in a leukemia, the white cells can be high, normal, or low. There is an association. B, it is characterized by pancytopenia and increased reticulocyte count. Of course, pancytopenia is there, but now aplastic anemia is a condition where there's a problem with the bone marrow failing to really produce the cells. So the reticulocyte count is actually going to be low because the problem is coming from the bone marrow. And then most cases are acquired and caused by autoimmune pathology, and this is true. Majority of the cases of this aplastic anemia are acquired and also caused by autoimmune pathology. For example, if someone is undergoing radiations, that can cause a destruction of the bone marrow. often associated with lymphadenopathy and hepatomegaly. No direct correlation really with hepatomegaly and splenomegaly. Maybe unless if we're talking about condition like lymphomas. 27 is saying a 38-year-old male presents with feelings of nausea, fullness, and bloating in the upper abdomen. The pain is relieved by eating but recurs 2 to 3 hours after a meal. He denies any melena or hematochezia, early satiety or dysphagia or weight loss. He takes ibuprofen daily for chronic knee pain. He eats a diet full of full processed and high fat food and admits to drinking a few beers on the weekends. Exam is normal, including a rectal exam that reveals a brown stool. A full blood count is normal, as are serum iron, ferritin, and transferrin. What test has the highest sensitivity and the specificity for H. pylori as a cause? So if someone has got PUD, it can be either gastric or duodenal. For duodenal, when you eat, you feel better. For gastric, it worse. So this is likely duodenal ulcers. So now what tests have got higher sensitivity and specific for H. pylori as a cause of the symptoms in this patient? Fecal antigen testing, urea breath testing, serologic titer testing for H. pylori, esophagogastroduodenoscopy with a biopsy. Any thought on this one? Okay. Now, so for this condition, likely this is going to be okay. Likely can be PUD, right? That is one chance. PUD. Now, remember in this question is that there is no melena, there is no hematochezia, right? No early satiety or dysphagia or weight loss. It takes ibuprofen daily for chronic pain, and then admits, of course, drinking. Now, besides hematochezia, I mean, besides PUD, it can also be a cancer here. So for me, the best thing that we can do is an esophagogastroduodenoscopy with PUD with a biopsy. This one will help us to view what is happening in the GIT, and a biopsy can also help us to rule out in case it is a carcinoma. Urea breath test is very good when it comes to diagnosis for H. pylori, of course, uh, specifically when it comes to the what this pelvic, the peptic ulcers. The urea breath test is very good. But when we want to determine, in this case, we want to determine the cause, an esophagogastroduodenoscopy is going to help us to see an ulcer, and the biopsy can actually help us also to rule out a carcinoma. So the sensitivity and specificity for urea breath test is really high, going all the way up to 90 to 95%. But for me, I'm also thinking of ruling out other what could have caused the symptoms besides just us thinking of an ulcer, because H. pylori can also be there and predispose someone to a carcinoma in the duodenum. So that's why I would go for D. In case someone has a different thought, please you can feel free to present yours also. 28 is saying an 80-year-old woman is brought to the clinic by her family with concerns of forgetfulness, including getting lost around her home for the past 1 year. You are concerned that she has Alzheimer's dementia, but would first like to exclude the irreversible cause of her complex. Maybe she's forgetting because of something else. Which of the following is not a reversible cause of dementia? HIV, syphilis, hypothyroidism, vitamin B12 deficiency. Any thought on this one? Okay, I've seen our doc who has posted A. Why do you think A, doc? So for me, I can remove D. There's a HIV associated dementia. Syphilis can as well result in that. Hypothyroidism can also cause forgetfulness, right? But for vitamin B12, so HIV, yeah, can't be cured, but let's say if someone is on treatment and then the CD4 count is going high up and then the viral load is reducing, would they still continue with the dementia? They can actually be helped, isn't it, in that case? Dementia is actually going to be in stage 4 of HIV. HIV associated dementia, that's stage 4 of HIV. So this one can be reversible. But vitamin B12 is not specifically related to causes of dementia. 29 is saying an 18-year-old man is brought into the emergency room, pulseless and undergoing cardiopulmonary resuscitation. He collapsed while playing football. There is no history of trauma and no prior history of cardiovascular disease. So the following conditions would most likely be identified at the time of autopsy. Normal findings on anomaly, left coronary artery, ruptured aorta, hypertrophic cardiomyopathy. Any thought on this one? All right. So it is hypertrophic cardiomyopathy, and this is one thing we need to know about. We have got three types of cardiomyopathy. We have got dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is the commonest cause in the young people of sudden cardiac death. Someone is playing football, they end up dying, just falling, and that's how they go. Okay, hypertrophic cardiomyopathy. A 50-year-old obese man presents with headache and complaints from his wife that he snores a lot in his sleep and at times stops breathing. Which of the following statements concerning obstructive sleep apnea syndrome is true? Men and women are equally affected. Copulmonary and not systemic hypertension is usually seen. Sedatives are often useful in the improvement of quality of sleep. Personality changes may be the presenting complaint. Any thought on this one? And it will be our last question for now. So obstructive sleep apnea syndrome is a sleep related breathing disorder where there's going to be repeated episodes of airway obstruction during sleep, and that is going to lead to disruption of sleep and oxygen desaturation. So the features is going to be recurrent apneas, hypopneas during sleep despite continued respiratory effort, loud snoring, gossiping, choking, excessive daytime sleepiness, fatigue, poor concentration. So this is changes in behavior. Morning headaches, dry mouth, widespread apnea by bed partners. I mean, witness the apneas by the people that you sleep with. So the pathophysiology is because of a collapse in the pharyngeal muscles during sleep, and that leads to this intermittent hypoxia, hypercapnia, sleep fragmentation. So the diagnosis, you can do a home sleep apnea testing. Okay. Risk factors for this condition includes obesity, Eshadi central, male sex, age greater than 40, cranial facial abnormalities like retrognathia, and then enlarged tonsils like or even the adenoids, alcohol or sedative use. The complications includes hypertension, coronary artery disease, stroke, type 2 diabetes, cognitive impairment, motor vehicle accidents due to sleepiness. So in this condition, it might present actually with personality changes, for example, poor communication, okay, and such. So that is with this question here.